to have you join us. All right. I'd like to get started, and we'll be providing some of these links along the way, but I'd like to allow Scott, who's going to be sharing background about the global burden of disease, to share his screen and start with an overview of this, one of the most profoundly important data sets and estimate sets that exist for educators and for regulators to be able to track and think about major trends in morbidity and mortality around the globe. Scott?
Well, thank you, Carol, and thank you for that sterling introduction. When you have it all listed out, it really does feel like there's a lot of partners that make this work. And I've been really privileged to be able to present the work of GBD to various groups in various capacities, including educators like yourself. Before I get started, if people could use, we'll see how this works, but use the raise hand function if you have some familiarity with the global burden of disease, just to get a basic read on, our understanding. I see a fair amount of good active users of this tool, so that is great. So yeah, as stated before, I am on the global engagement and outreach team. This is a team of about 12 members at IHME, and we manage what we call our collaborator network, which is a collection of around 12,000 researchers, educators, practitioners in health, people working in ministries of health who are completely instrumental in making the global burden of disease work, and also allowing for it to be used. I explain more about the global burden of disease, you'll see why it's so important to have a broad global community of people who are knowledgeable in it and people who can better scrutinize our work to make it better for each iteration that we move forward with this research project. So I'm going to share my screen now and give a brief overview of the global burden of disease. It is an incredibly large research project. So what we're going to cover today is really just going to scratch the surface. I could give a 2-hour lecture on the methodologies of each part of the global burden of disease, but that's not what we're here for. We're here to learn how we can use these estimates, how we can establish trust in them, how we can better use them as a tool to further another investigation. So I want to start with IHME and what we do, what our vision is, what our principles are. This is kind of our mission statement, our vision, and there's a lot of fundamentals that are down at the bottom, and that's what we're here for today. Knowledge sharing, collaboration, the scientific excellence that you all embody. But at the top of this pyramid, that vision that we have is for all people living long lives in full health. As global health practitioners, that's what we should all be aspiring to. But the question fundamentally comes down to is how do we achieve that? Well, our small piece of the global health community is to provide some research and some data that can underlie some efforts out there in the field. We have a number of research projects at IHME. We have, of course, the global burden of disease, which is what we are here for today. financing global health, which is the money's flows of global health funding, what projects they're going towards, local small area estimation, which is trying to map things on a 5 by 5 kilometer grid, like poor sanitation, diarrheal diseases, so we can really understand where implementation strategies need to go in. We use the GBD that we have, those estimates, and we forecast that out to 2100. Always a difficult year to say and a difficult one to think about. We forecast that out. It's really important for policymakers to see if we're on our current track, what are things going to look like 50 years in the future, 70 years in the future, and how can we change things for the better? We also just published on antimicrobial resistance, being close to emergent problems in the health sphere. But back to our mission statement and why we do all of this research, and that is that everyone deserves a long and healthy life. But the question is, what is preventing that? And to understand that, we need to have estimates and data and numbers that can further the evidence of what is preventing this mission statement, this vision of everyone living a long life in full health. So there were no good measures of disease burden. This is back in the before the global burden of disease really started. There was no good measure of burden of disease to set research priorities, to inform health agendas, to manage program implementations. All of these things are, the numbers that you need to see if your program is effective or if your program is needed. So you need numbers in order to evaluate what works, and you need numbers to evaluate when a program should be scrapped, when it's not working, when we need to rethink what we're doing in global health. So in the late 1980s, this is going back to what I was saying, there was no coherent estimates. We had all researchers who were looking in diseases and injuries and risk factors, and they were all coming up with their own estimates. The creator of the global burden of disease and the director of IHME, Chris Murray, he was at the WHO and he went over to the malaria people and he said, how many global deaths are there? And they gave him a number. Then he went over to the diarrheal diseases people and asked them, how many global deaths are there? They gave them a number. Went to all of these different research areas at the WHO, asked them how many deaths there were, and then he added up all of those deaths, and it was 5 times the number of global deaths, all over. So obviously something was wrong. And when you have 5 times those deaths, you have deaths that are overlapping. We don't have a way to compare what these diseases, the impacts that these diseases are having on the globe. We had no way to compare diseases on how they impact people differently. Some diseases may outright kill you, but some diseases are going to give you disability for a very long time and impact your health. How do you compare those diseases when the tools in our tool belt for so long have been looking at deaths or looking at the prevalence of diseases? So we needed to rethink the way that we approach looking at disease. And that is come to the global burden of disease. So it started as a WHO study. It had 8 regions, 107 diseases, and we were just looking at those 8 regions. In South America, diarrheal diseases are causing this much burden of disease. In Asia, ischemic, or maybe ischemic heart disease. I don't know what was exactly in that 107 diseases, but that was in 1996. As the years have gone on, we have expanded and enlarged what we are looking at in the global burden of disease. We just published the 2021 results a couple months ago, and in that, we're looking at 371 diseases. We're looking across 88 different risk factors. We have 204 countries, up to actually, I think 1,600 geographies that are actually estimated, because we're going into countries and looking at the difference between states, between provinces, between principalities. Because that is a incredibly important way for us to look to understand health. Importantly, as well, we have now 12,000 contributors to this project across the globe. So, what is the global burden of disease study? I'm just going to read verbatim this summary of it. The Global Burden of Disease study is a systematic, scientific effort to quantify the comparative magnitude of health loss due to diseases, injuries, and risk factors by age, sex, and geographies for specific points in time. Those words are bolded for a reason. They're incredibly important to the work that we do. It is systematic. We follow the same system. We're not, nudging numbers because, to fit certain priors. We do, have set priors based on our statistical analysis, but, we do follow a system in how we collate the data, how we separate the data, how we then estimate on the data. It's scientific. We use the best evidence, the best studies, the best models in order to get to our final estimate. It's comparative. This is incredibly important. And when we get to going through the visualization, it's the reason why we call that GBD Compare. We make this project in order to compare diseases to other diseases when they cause different outcomes, and compare countries to other countries when they might have different ways in their own national data to measure diseases, whether that's using different ICD codes or different case definitions of different diseases. We need to be able to compare like to like, and through our harmonization, we're able to do that. And finally, the magnitude of health loss. Looking at just the number of deaths or looking just at prevalent diseases is not what's important to us, because we are trying to get to a place where all people are living in a long life in full health. So we need other measures that tell us when people aren't living a long life and when they're not living in full health. So we provide a comprehensive, comparable picture of mortality and disability. We quantify health loss from hundreds of diseases, injuries, and risk factors so that health systems can be improved and those disparities can be eliminated. And a really important key here on this slide is that international collaboration is necessary for any global project, and that includes our own. So when the global burden of disease started in 1995, our international collaboration looked like this. I think there is a dot in Geneva, and there's a dot in Boston. We was working through Harvard and working through the WHO. And this is how we got to, 8 locations, 107 diseases. A huge undertaking, but when you expand it, you need more people who have the expertise in more areas around more diseases. When we published in 2010, our international collaboration looked like this. So we're growing in the numbers, geographic representation, disease experts, experts in different areas of health. But we still have room to grow, and we're still expanding the number of things that we're looking at. Finally, in 2024, this is what our international collaboration looks like. We have 12,000 collaborators in our network. When we publish a paper, or before we publish a paper, we disseminate it to the network and get them to look at these estimates, give a check on, is this reasonable to you? We don't understand, we don't know this province in Kenya that we're estimating. The data tells us this, but if there's something that's wildly off, you would be the expert there, and it's necessary for us to have that international collaboration in order to see those things. There's also a part of equity here, that a lot of our collaborators are also the data providers. And in the publishing of papers, especially, this type of paper that's like a meta-analysis that we have, millions of data sources, we want to be able to attribute everyone who's providing data to us. And they should be attributed for their efforts to bettering the science, bettering health, bettering this global community. This is another version of our map of global collaboration, and we have pretty good coverage around the world. Obviously, some locations have more collaborators than others, and we still have some gray areas that we're trying to fill in. So if you're from Madagascar or what is Turkmenistan, please let us know, and I think we'll add a link to joining the collaborator network in the chat. So why GBD? Three main points that were kind of in those bolded words in describing what the GBD is. One is that it provides a burden measurement of health, and I'll talk a little bit more about that. But we want to be able to look at things that are preventing long life and things that are preventing full health. So instead of just looking at deaths, we need to look at the time of those deaths. And instead of looking at just prevalence, we need to look at how severe the disability was for that disease. Comparability. This goes back to being able to compare like to like. Different locations across different diseases. And also completeness. If you're looking at a data series, it may have 1996 and the year 2000. We want to be able to fill in that gap in between. We do that through statistics and estimates, and fill in a 31-year time series. We fill in where data doesn't exist in different locations using assumptions that health conditions will look similar to another country or similar to another year, or they'll be based on other things like income or access to sanitation or the use of mosquito nets. So we use estimates to fill in those gaps where data is missing in order to produce that comprehensive, comparable picture for every country in the world. So let's talk about measuring health loss. We use a burden approach to measuring health to capture all aspects of health loss. So I've talked a lot about how deaths is an incomplete picture. They just tell us one thing. They don't tell us anything about that long life story. Instead of looking at deaths, we look at premature mortality. What we do is we look at the best performing life expectancy, make an artificial life table through all the lowest mortality rates in every single age group and get at birth, a person is expected, if they're in the best locations, the best demographics, to live about 88 years at birth. It gets, older as you get higher, as you go through different mortality periods, but that's simplified what it is. So if we're to imagine two people, and they're both expected to live that 88 years, and one of them dies at, say 78. Another one dies at 20. Should we count these two deaths the same when we're trying to describe how people are not living a long life? You know, these would just be two deaths, but if we're just looking at deaths, then these are counted the same, and we need to show that one has a bigger impact than the other. So what we do is we actually measure the time lost from premature mortality, and we call that years of life lost. And that's our measurement of deaths, our mortality measurement on burden. We also need to look at disability. That's that other part of that statement, long life in full health. So what is preventing a person from living in that full health? Well, traditionally, when we're looking at diseases, we're looking at prevalence. How many cases for how long of whatever disease. Well, instead, we want to look at disability. And what we do to look at that disability is we take all of the diseases, separate them into the health states that they're causing, and assign a weight to it, where 0 is perfect health and 1 is equivalent to death. So someone who has mild distance impairment, vision impairment, like myself, has maybe a 0.01 on the disability. I'm not living in full health right now because, corrective lenses might lend me to being so. Someone who has a spinal cord lesion at the neck untreated has 0.72 of that disability weight. And we fill in the gaps. Bipolar disorder, severe back pain, a number of different health states have a number of different disability weights to them, different measurements of their severity. And what we do is we multiply the duration of that case times the severity, and we get years lived with disability. So that's now our measurement of that full health. How do we get people living long life in full health? We need to have a measurement of that as well, and that's years lived with disability. So we now have our premature mortality through our YLLs, and we have our living with disability through our YLDs. Finally, we need to have an overall measurement of burden. And because these are both measurements of what is the years and how much severe or how severe your disability was for how long, or how premature your mortality was and how many years, we can simply add these two measurements together. And when we do that, we get disability adjusted life years. And that is our standard measurement for showing what the burden of disease is for any location, any disease, any age, any year from 1990 to 2021. Slide got duplicated there. So back to the why GBD now that we've covered burden measurement a little bit. I want to talk quickly about those other two areas, comparability and completeness. So with comparability, we have a lot of data sources in the GBD. This is a map of the total number of data sources by location. You can see that in the United States, Canada, Mexico, we have between 2,000 to 14,000 separate data sources. A number of data sources in all different countries. And sometimes these data sources don't agree on their terms. They don't agree on their definition of a disease. They may be measuring something that can inform something else, but it's not what another study is measuring. So how do we compare all of these disparate studies? What we do in order to achieve this comparability is we have a number of crosswalks or a number of harmonization of the data. A great example is looking at ICD codes. This is what ICD codes were used over time. We need to get these to agree with one another. How are we going to compare 1997 data when half of the countries are using ICD-9 and the other half of the countries are using ICD-10? We need to be able to harmonize these data so that they're actually comparable. Finally, completeness. We want to be able to measure as much as we can measure. I think there's now more than a billion rows of data in probably more in GBD. And that's because we're measuring more and more things. So, at the geographies, we have a number of geographies that we separate out into these regions. We also we separate them out into super regions, into geographical regions to help us with the modeling. We're also diving into in-country. We have a number of subnational locations where we're making estimates, like the states of Brazil, the oblasts of Russia, India, China, the upper tier local health authorities in England, if you want a very administrative term. Because getting to greater and greater detail is incredibly important for making determinations in health. We look at a number of different age groups. We look at all sorts of neonatal age groups, 0 to 7 days, 7 to 28 days, 28 to 365 days. And then after 5 years old, we model things into 5-year age bins. So you can actually look into the age groups that you are interested in, because we know that disease doesn't follows an age pattern, and as researchers, we need to be able to look into that. We, of course, model things by sex, male, female, and both sexes combined. We also have 31 years of analysis now. So 1990 to 2021, our GBD 2021 estimates being the latest version published a couple of months ago. And when we publish a new round of GBD, we re-estimate the entire time series. This is to ensure that we're incorporating all the new data, all the new methods, all of the new insight that we get from round to round. We also model 371 separate causes. These causes are in a hierarchical cause list. Now, what that means is that each level of the cause list that you go down gets to greater and greater detail. As we start at level 0 of the cause list, that's our all cause. When we move down to that level of detail, we then split it out. into communicable, maternal, neonatal, and nutritional diseases, non-communicable diseases, and injuries. These types of disease categories. Group one, as we call that first one, are more these diseases of poverty almost. Non-communicable diseases are are growing chronic diseases globally, and injuries need to be approached separately. When we move down that hierarchy now to level two, we split these out into more research areas. So we've got diarrheal diseases and lower respiratory infections as their own area of diseases. We have cardiovascular diseases as their own cause to look at. We have transportation injuries as their own cause to look at. When we go further, we can then look at that cardiovascular disease. We can then look at ischemic heart disease. We can go down a level further and separate stroke into intracerebral stroke and ischemic stroke. We want to be able to achieve the highest level of fidelity, of clarity, of detail that we can provide. But of course, we need to have data that can underlie all of these measurements. So here's a good example of how this cause hierarchy works. We have our all cause, we move into that group one, which is the communicable, maternal, neonatal, and nutritional, then to diarrheal and lower respiratory, intestinal, infectious diseases, and finally at our level 4, typhoid fever. We also measure 88 separate risk factors, and these are also in a hierarchical list, list of 4 levels. So our behavioral, our environmental and occupational, and our metabolic risks. And we can see kind of how this breaks down. We'll first look at that all risk. You know, what is the health loss due to all risks that are measured in the global burden of disease? What is the health loss that's due to environmental risks? This will include poor sanitation. This will include air pollution. This will include indoor cooking. Then what are the health losses due to occupational risks? Then occupational carcinogens, and then occupational asbestos. Again, going down those levels to get greater and greater detail and clarity to get to the answer of your health question. So these are the key components that we have in the global burden of disease estimation. I'm not going to go through all of what we do to estimate it, but we start with our all cause so we can get a total number of deaths. So we don't have that 5 times the global number of deaths all over. We need to start with a number that we know. Then we estimate our all-cause mortality. We split up that total number of deaths into percentage using the data. We now know that 20% of the deaths are due to cardiovascular diseases. We know that 15% of the deaths are due to ischemic heart disease. We split up that, what we call the envelope of the total number of deaths, into causes. We then estimate our non-fatal outcomes using some of the data or some of the estimates that we produced through causes of death estimation, like fatality, incidence fatality, and other outcomes can inform those non-fatal estimates. And then we use those numbers and apply our risk factors using studies that allow us to determine relative risks and using data for us to see what different exposure levels are in different populations. So we apply different studies, get that relative risk, calculate what percent of health loss is due to a risk factor, and then see what our number of health loss is and just apply that percent to that. And you can get to that attributable risk factor attributable burden. And finally, what is the use of making all of these estimates, producing all of these data without it being able to be explored, being able to be looked at? And we have a dedicated team at IHME that produces a number of visualizations for all those different research projects that I talked about, that low small area estimation, that financing global health, the forecasting, but our flagship that allows for us to explore the global burden of disease is GBD Compare. So I would like to share with you a little bit of GBD Compare now. I should have it pulled up in front of me. Great. And Carol, where am I on time?
You have plenty of time left.
Okay. Perfect. So we have GBD Compare, the visualization tool that allows for us to actually explore all of these estimates that we're producing. When you open up GBD Compare, you open up on this page. It's a little bit confusing. It's a little bit scary. It's maybe not that easy to immediately read. But I love that it starts here. And that's because what we're looking at is a picture of us in the world for 2021. This is everything that is preventing someone from living a full life, and everything that's preventing them from living a long life, and everything that's preventing them from living in full health in one image. And this one image shows us how much power there is in this tool, because everything that we're looking at here, we are able to dive into deeper. When a question arises from looking at these data, we can use this tool to explore, to find out why, or to find out what further research might need to be done in order to better understand the problems or the conditions that we have. So I'm going to explain just a little bit about using GBD Compare. And in doing that, what I'm going to do is talk about different locations, different regions on this tool, one by one, in order to allow you to better navigate and move around, because it's a very big tool. It's a very complicated tool, and hopefully by the end of this, I'll give you just a little bit more understanding to allow you to explore even further. So I'll be talking about this settings panel. I'll be talking about the different views that we can use, and also when and why we should be using them. I'll talk a little bit about this single explore and compare panel at the top, and then I'll talk about these buttons up at the top here that can allow a lot more further collaboration using this tool. So starting off with the settings panel. The settings panel is what allows us to change what we're looking at. It allows us to change all of those different areas of completeness that I was talking about. Allows for us to look into different sexes, different locations, different causes, different age groups, different years. The settings panel will change depending on what view we're looking at. But there's a few things that remain pretty constant from view to view, and these are our demographic settings. So what we have here is some pretty simple demographics that we can use in order to explore these data. When we're looking at ages, we can instead look at this in the under 5 age group to see what health loss looks like. We can look at the over 70 age group to see what health loss looks like. Also, sex will remain in most views. Other views, they're going to change a little bit depending on what we're looking at. So when we start off on GBD Compare, we start off on this tree map. And the tree map allows for us to look at all diseases at once. What this is really showing us is a pie chart, a square pie chart that's showing the distribution of health loss. So here, 6.5% of health loss is due to ischemic heart disease in 2021. And 7.4% of health loss was due to COVID-19 in 2021. So because all of the diseases are on this page, over on the settings panel, we're not able to select diseases. We are, however, able to change what distribution we're looking at. So instead of looking at the distribution globally, we could look at the distribution in Armenia, say. So it looks a little bit different there. The settings panel also allows us to look at different aspects of burden. So it starts us off with the disability adjusted life years, or DALYs. And this gives us a good picture of overall health loss. But as researchers, we know that one measurement is never the full answer or the full picture. So this also allows for us to look at disability. So we can see what causes are causing the most disability. Now we're looking at Armenia for both sexes in 2021, and we see that depression and back pain are causing the most disability. We could also look at deaths in this view. I find this way to be a really good way to understand the tree map. Everybody understands percentage of deaths. Almost 30% of deaths in Armenia were due to ischemic heart disease. 16.5% of deaths were due to COVID-19 in 2021 in Armenia. You may notice that I talked about other measurements that we use in the global burden of disease, particularly the YLLs, or years of life lost, that measurement of premature mortality. That is not on this page right now. As I stated before, GBD Compare is an incredibly complex visualization tool. And as such, when new users come to it, we provide them with the basic settings. We don't want them to immediately get lost. So there's a bit of restriction on what we can look at. We're only immediately looking at those basic settings. We're only looking at ILDs, DALYs, and deaths. But because I know you will all become advanced users of this tool, we're going to look at those advanced settings. So when I click this little text here at the top, use advanced settings, use basic settings, we can see that our options expand. This display, which I'll go into in a bit, used to only say causes or risks. Now we can look at other measurements that we make, like etiologies, impairments, and injuries by nature. That measures, that was just 3 buttons of deaths, YLDs, and DALYs. Now we have a drop down that we can look at a number of different measurements that we make. We now can look at that premature mortality. We can see how, by comparing deaths and premature mortality, why this is an important tool, measurement tool to look at, as it enlarges some deaths that are causing, or some diseases or injuries that are causing that premature mortality that should be of greater importance to researchers or policymakers, like road traffic injuries, which grew in the number of the share there. The advanced settings also allows for us to look even further into different demographics. So when we were only looking at those basic settings, we were only able to look at 6 different age groups, all ages, under 5, over 70, some older adults, like 50 through 69, I think. When we're looking at the advanced settings, we are able to look at a much larger suite of these age groupings. So 5 to 14, 10 to 19, depending on what your interest is, you can look at these different age groups. If we actually scroll down all the way to the bottom, we can select age specific, and we can look at each individual age group that is estimated in the GBD. So it starts us off with this slider in 0 to 6 days, or we have congenital birth defects and neonatal disorders. We can slide this to look at any age group we want to, say 20 to 24-year-olds. We could look at, males. 20. You can see, how big that road traffic injury problem is for that age group. Finally, on the settings panel here, as it relates to the tree map, get a little bit back to global. I want to talk a little bit about this level slider, and this goes back to that cause hierarchy that was mentioned, those 5 levels starting at level 0, level 1, and level 2, 3, 4. We can explore that in this tree map by using this level slider. We can slide it all the way here and just look at these level 1 causes. Here we have our non-communicable, our group 1, that communicable, neonatal, nutritional, and maternal injuries. And we also have, for 2021, our other COVID pandemic related outcomes, which is excess mortality that didn't fit into a bucket. We needed to put it somewhere because we needed to capture all health loss. We can slide this over to level 2. We see this broken down into our 21 different level 2 causes: cardiovascular diseases, respiratory and tuberculosis, chronic respiratory diseases, digestive diseases. Again, to level 3, we now have cardiovascular diseases into ischemic heart disease and stroke. Level 4, that stroke is intracerebral hemorrhage and ischemic stroke. We get to levels and levels of detail by looking deeper and deeper into the cause hierarchy. But we may not be interested in this full picture of health. We may only be interested in one disease. And that's why we need to have different views in order to look at it. Starting at the top, a great way for us to look at things is in our map view. And you'll notice here that the settings panel has changed a little bit. A lot of the things have remained the same. We still have our measurements we can look at. We still have our ages we can look at, our sex we can look at. But now we have, instead of global, we can look at cause, because we're not or instead of location, where you can look at cause, because we're not looking at all causes. We're looking at all locations. So now, instead of selecting different locations to look at, we can select individual causes to look at. Setting to play with. We have our metric setting. So every single estimate that we measure in 3 main metrics. We measure the number, the total counts of things, whether that's the number of deaths, the number of years that we lost from premature mortality. We measure it in rates. So what are the deaths per population? We report that in per 100,000 of population. We also have percent. So percent is of the total number of deaths, what percent is due to this cause, or the total number of health loss as measured in DALYs, what percent is due to diabetes. So we can start to explore, these different metrics. Some metrics are more useful than others depending on what you're looking at. For instance, if we're looking at a global map and we're looking at the metric of numbers, it might not be useful. We have very large populations that we measure in India and in China that's just what shows up on the map. If we are looking at percent on this map, well, here it's also not useful. When I go here, it's 100% of that premature mortality. This is because I right now am looking at total all causes. And that's why it's important to look at how your settings have changed based on what you're looking at. So I'm not interested in what percent of all premature mortality is due to all causes. I know that's 100% because we measure everything. I'm interested in lower respiratory infections. So if we type in, we can get that to come up. We can select lower respiratory infections, and then we can look at what percent of health loss is due to, or this is premature mortality. What percent of health loss, as measured in disability adjusted life years, is due to lower respiratory infection? And we can see it here. Another area that was unavailable to us in our previous view, because it was looking at things that we can measure from a population, is one other measurement that's incredibly important when we're comparing. GBD Compare, creating the global burden of disease for comparability. We need to be able to compare effectively. And we know that disease is not the same depending on how old a person is. Your disease pattern changes along your age trajectory. And so different populations look very different for how their disease patterns look. So when we're comparing different years, when we're comparing different locations, we need to have a measurement or a tool in order to compare these. So we have our age standardized rates. We use the global population structure, make everyone adhere to that global population structure, adjust the rates accordingly, and now we're able to look at, to compare countries that have very different shapes of their population, to show, how this is incredibly important. We can go back to all causes and we can look at deaths. And when we're just looking at all ages deaths, we see that post-Soviet states are, far and away the largest. They're the ones who are red on the map. They're the ones that have the highest rates of death. Well, these are quite old populations. So they're going to be impacted more by that. It's impossible for us to compare that older population of Russia, of Belarus, of Ukraine, with sub-Saharan African populations, which have that very wide base of their population pyramid. So we need to standardize that in some way. And when we're using those advanced settings, when we have more options of ages, we can select that age standardization and actually make effective comparisons. There are other ways that we can make comparisons in GBD Compare. It is, of course, called GBD Compare. We have our arrow diagram. This allows for us to take 2 years as a snapshot, look at the composition of what their health concerns should be based on relative ranking, and see how they've changed. So here we have our global deaths, age standardized in 1990 to 2021. You'll notice that as I move from view to view, the options that I've selected in the previous view will remain. So it allows for us to really quickly explore through different insights in our data. So we can use this arrow diagram, as we call it, to see how, health has changed. Looking at level 3, we can see that we have, great strides that we've made in tuberculosis. It's gone from the number 6 cause of death for males. See if that changes for age standardized. It just might if population structures have changed. Has gone from 7th to 13th in deaths from males. So great strides in that overall ranking. Is there prioritization setting that needs to take place as we see chronic diseases growing in concern globally? We can see that epidemiological transition, that transition from those group 1, communicable, neonatal, nutritional, and maternal diseases, going down in their relative ranking, and chronic diseases and non-communicable diseases being a greater cause of impact on health. So we can use this arrow diagram to explore that. Everything in GBD Compare, we're able to hover over, and this will give us more insight into what it is that we're looking at. So when we hover over these different causes on here, it not only tells us what the rates are from year to year, but it tells us what the actual change is. So we see the ischemic heart disease, which remains the top death from 1990 to 2021 for males globally. It actually increased by about 21%. Stroke went down from the 2nd ranking cause to the 3rd ranking cause. But when we hover over it, we actually see that it increased. This is an area to be careful with this view. Just because a disease changes, goes up or down in its ranking, doesn't mean that the point change of its rates moved in the same direction. The diseases around it may have changed. And that's why it's important for us to have these estimates of all diseases together, so we can see, how diseases are acting relatively to other diseases. Here, stroke went to level 3 because we had a new emergent disease on our ranking table here with COVID-19. So that's the tree map and how we can use that effectively to make different decisions, different insights in health. We have I'll go into the pyramid view, and this just allows for us to look at different locations by sex on each side and compare them. So we can see sex differences by causes, and we can compare that across country. Anytime in GBD Compare that you get a new panel over here on the right with all of these options here, this actually allows for us to move to change more options, to allow for us to get deeper insights into these diseases or these injuries. So we actually have a drop down here again. It starts us off looking at overview level 2, but it also allows for us to look into any of these separate level 2 diseases. So instead of looking at all diseases, because we're looking at sex differences, maybe I want to look at substance use disorder and what the sex difference is. So we can use these options here to get better insight into the sex differences, or in other views, which we'll go into, the risks that may impact things. Anytime something is underlined here, we can actually click that again. So I can click drug use disorders, and we can see the great impact that opioid use disorder has in the United States. We have a patterns view that allows for us to actually adjust the x-axis. Let's go back to our overview level 2 here to get, a good overview of all of the causes here. And we can see that, the differences that age makes on your health. So if we're looking at this is deaths. If we look at DALYs, we'll see how much young ages, the rates, how large they are. Very small populations, very big impacts on health. What is useful for us to be able to get insights here is maybe looking at this by numbers. What are the numbers of deaths? If you are a policymaker, this might be a concern for your funding. We can look at the percentage here. So what does the movement of health look like through a person's life? We can see these enteric infections, neglected tropical diseases in younger ages. We can see the transport injuries and self-harm and interpersonal violence in the 20 to 30-year-olds, and then chronic diseases, neoplasms later in life. Another really useful tool in global burden of disease is for us to make that comparison. And we can make that comparison while using the heat map. The heat map shows that ranking, kind of like what we are looking at in the arrow diagram. But we can look at this instead of across 2 different years, we can look at this across different locations. So this shows our ranking of different diseases across a different number of locations. We can change these locations. We can add one like Tanzania. And it'll just add on to our heat map here. Or we already have groups. These are our different regions. These are WHO regions, World Bank regions. We can look at World Bank lower middle income countries, and it will fill in all of those countries. A lot of countries here, but I'm interested in looking at countries by their income grouping, and I'm interested in how all of these countries compare to Ghana. I can click Ghana. It'll rank things according to Ghana, and I can see where things stand out. So, you know, Ghana, malaria is number 3. Are there any countries in here where malaria is a much lower cause, where malaria is endemic, but it is not causing as much death or disability than Ghana? What are they doing? Is this implement in Ghana? So the heat map is an incredibly useful tool for us to benchmark what we're doing and what we could be doing. We can benchmark these things across time. I think I still have the low income, so this might be a very messy line graph. But this is your simple line graph looking at rates of death, I believe. No, looking at DALYs, let's look at both sexes. We see here Haiti, earthquake 2010, I believe. But we can, compare a smaller group of countries, maybe Southern Latin America, where we just have 3 countries that we can compare them across this time period. We see the impacts that COVID had on these countries here as well. And then 3 more views that I haven't covered that are really important. First is, these are getting to our quite complicated views. First is our life expectancy decomposition, which may or may not be working for me, which is always wonderful for a demo. See if I can just refresh this. So the life expectancy decomp, what we did in our 2021 results is we looked at what the changes are in life expectancy, how many years were gained or lost, and then we broke that down by using mortality rates and the changes in mortality rates into different causes. So, if someone had 5 years gained in life expectancy from 1990 to 21, we can say 2 of those years were due to improvements in neoplasms. 1 of those years was due to improvements in cardiovascular diseases, but they were held back by 0.5 years because lower respiratory infections got worse. Let's see if this works now. And it doesn't. But this shows these 2 points of 1990 and 2021. And when I tell the visualization team to fix this, you'll be able to explore that and see how those changes are broken down. I want to pivot now to risks. A very important part of our estimation. So when we're looking at this display, we can, we are looking at cause because it starts with the most simple way for us to interpret things. But we also have a really robust set of estimates on risk, and GBD Compare also allows for us to explore these. So instead of us looking at cause here, we're going to shift to risk. When we do that, you'll notice that the colors on this map change. Before, we were looking at colors that were lighter and darker, depending on how much the rates are growing or shrinking. Here, each one of these little squares gets broken down into risks. So this is how we model risks. We model risks as percent of that cause that's due to risk. When we're looking at ischemic heart disease, we see that ischemic heart disease causes 6.6 of total DALYs of total health loss, and 92.3% of ischemic heart disease is due to risk factors. Diabetes, 100%. High fasting plasma glucose is a modeled risk. Road traffic injuries, 32.4% is due to risks. Each one of these views can also be explored by looking at risks. So we can look at our map view. And here we're looking at the total health loss that's due to risk factors that we model. Those 88 risk factors are not inclusive of everything. We know that there's genetic risks. We know that there are other risks that we're pretty sure are doing something, but there's not enough scientific evidence for us to include in the study. So of those that we include, we can see what the health loss is. So, 15,000 DALYs in the United States are due to risk factor. Remember, this is a measurement of years, right? This is 15,000 years that are lost due to risk factors in 2021. We can see how that compares to Chad. Chad is more than double that's due to risk factors here. When we have our risk factors selected, we can actually select our different risk factors. So we can look at what the health loss is due to unsafe sanitation. We can see in this low Central African region how much unsafe water source is contributing to our health loss there. We can look at different measurement or different views that we're looking at as risk factors. So before we were looking at the ranking of causes, we can look at the ranking of risk factors, move this to our different levels and see how particulate matter grew in air pollution, grew into what impact it's having on global health from 1990 to 2021. We can see how great strides we've made with child growth failure as that has dropped. Each one of these different measurements that we or views that we have looked at, we can look at this through risk factors. So comparing country to country by looking at risk factors, comparing over time by looking at risk factors. Over time looking at risk factors. This is unsafe water source. You can see the drastic improvements that we've made. Haiti? No, Angola. In Angola there. By looking at this over time. There are a couple of views that are designed for us to look at risk factors. I skipped those when I started here, but I want to go into them now. The first one is this risk by cause. So every risk that we model, the way that we model it is that the outcomes from that risk have to travel through a cause. So it's not just that smoking kills you, it's that smoking kills you through lung cancer. So, each measurement of exposure that we have, we map that to a cause. And this view allows for us to see those pathways and how they work. This is ranked on our health loss due to risk factors with particulate matter at the top. And we can see exactly how that particulate matter is broken down by cause. So some of it is due to respiratory infection and tuberculosis. Some of it is due to cardiovascular disease. This is air pollution causing cardiovascular disease that is causing an impact on health. We can look at this just through deaths to simplify it. So here we have how high blood pressure moves through cardiovascular disease, ischemic heart disease. We see how particulate matter, the exposure to air pollution causes death through respiratory infection and tuberculosis, causes death through cardiovascular diseases. Before I was saying that anything that is underlined, you can click over here. That also works over here. So here we're looking at particulate matter. You can actually click into that. We can see the difference in ambient particulate matter and household air pollution. How much health loss there is due to these two separate sources of air pollution. We might only be interested in how risks affect our particular cause group. So maybe how risk impacts transportation injuries. And we can see the risks from occupational injury. We can see that low bone mineral density impacts transportation injuries. And of course, high alcohol use. We can use these different tools to allow for us to look at these associations between risk and cause. The last view is this overlap map. So risks are a little bit different than causes. One important thing about a cause is that you only die once. So when we measure causes, we determine through the data, through the estimate, what that cause of death is. And we'll say that cause of death was ischemic heart disease. It wasn't ischemic heart disease due to all these other contributing factors. We just have one cause of death on the death card. And it is they are exclusive to one another. There's of course comorbidity with our disability estimates, but risks are very different because risks interact with one another. And so we need to be able to capture that. And we do a thing in our modeling called risk mediation to capture the ways that high BMI and blood pressure may interact, different dietary risks may interact with one another. So we want to be able to show how we're capturing some of that. And that is what we can look to our overlap map here. This is not going to show us everything that our risk factors are doing. It's a quite simplified version of this. But this is our donut diagram because it looks like a donut. And what this is showing is what's captured by our different risk factors. So the blue is here we're looking at deaths. The deaths that are caused by the behavioral risks, so smoking, alcohol. The red here is the deaths that are captured by the metabolic risks that we model. High blood pressure, high fasting plasma glucose. And the E is the environmental risk factors that we model. Air pollution, poor sanitation, the wash ones, water, sanitation, and hygiene. We have some risk factors that overlap here. Some environmental risk factors that are causing deaths alongside behavioral risks. We have some metabolic risk factors that are causing deaths alongside behavioral risks. And here we can see that that's actually 7% of all deaths are from that overlap. We have our overlap here of environmental and metabolic. In the center, we have the overlap of all three of our risk categories. So, when metabolic, environmental, and behavioral risks interacting, that's 4% of all deaths are due to that interaction of all of those risks. Finally, on the outside is the unattributable burden. Again, we're looking at deaths here. We could just as easily look at overall health loss through DALYs. We could look at premature mortality through YLLs. But here we're looking at deaths. And we can see from our studies, 49.8% is not captured by risk factors. This doesn't mean that risk factors aren't impacting these deaths. Doesn't mean that these deaths are not caused by some risk. It just means that the 88 risk factors that we have in the global burden of disease study do not map on to these about 50% of deaths. And that is the donut diagram. The only thing that I haven't covered in here is the plot view. You can use this like a line chart, but also change the x-axis if you want. Can be useful for modelers as well. But that's a pretty brief overview of the settings and the views panel. There are a number of different ways for us to approach these data. And we want to have as many tools as possible to show the insights that you've gotten with your population health question. We can present this in a number of ways. One is just by looking at one view, say a map. Another is for us to look at this in an explore view. This allows for us to look at two different views at the same time. So if we're going to look at this in causes, say, we can look at, what the overall, this is deaths, what the state of the world is, how they differ from one another. This is just all causes deaths by location at the top. And on the bottom is what's the makeup of those deaths globally. We can see where the problem is worse, and we can see with what is the problem worse. We also can look at this by comparing different views. So we can compare across the year. Maybe we want to have 1990 at the top and 2021 at the bottom. Down here, when we are in the compare view, we can adjust these settings. So the top chart setting, we can look at 1990. The bottom chart setting, we can look at 2021. Here, it's really easy to see the impact that COVID-19 has on our picture of health. But if we move down to 2019, we can see the huge change that has happened in looking at the health landscape globally. That transition from communicable, neonatal, nutritional, maternal diseases of poverty, to chronic diseases, non-communicable diseases, that epidemiological transition. We can just look at that in one map. There's a number of different things that we can compare, and we can compare this through all of our different views. So we can look at our different maps. we can look at improvements in sub-Saharan Africa here from 1990 to 2019. That is looking at the compare view. And finally, what's the point of all of this if you can't share it? Up here at the top, we have some additional tools that allow for you to share this work with colleagues. One is download. I can just download immediately CSV files of the estimates of the data that is underlying these charts right there. Download all of the data that's on there. We also have the ability to get a screenshot from this and also go to GBD results tool, which is a tool that we designed that allows for you to download a lot more material that then can sit on any one chart. We have language here. So our collaborators, many of them have helped us with translating GBD Compare into a number of different languages, translating all the scientific terminology into Japanese. Hopefully I'll be able to find my way back. I do not speak Japanese. So we can actually share it with whomever you are working with, if English is not their first language. And finally, we have the share button here. You can get this directly to an email. You can share it on Facebook or Twitter if you like. But importantly, we have the copy link here. And when I click that, what it does is it copies a permalink there. So if I were to start a new tab here, paste it there, it's going to preserve the exact view that I had, down to the Japanese, down to it being in these two different views. So you don't have to describe to a colleague, well, select these different options in the panel. You can get exactly what you want them to see and then deliver it to them. So hopefully this is just scratching the surface of all this tool has to offer. And I really hope that you get excited by being able to explore this. And yeah, I look forward to any questions that you may have. So thank you for your time.
Scott, that was phenomenal. And I realized that all of us are probably, even those of us that use it regularly in classes and in research, all of us are likely to have just been dumbfounded with the handful of additional items we've just learned in this quick tour. Allie wanted to jump in. Why don't you go ahead, Allie?
Thanks so much, Carol. And thank you, Scott, for this really excellent presentation. We had just a few questions in the chat that I wanted to make sure that we addressed. Scott, I think we'll be able to provide some good insights. The first is, can you help us understand how to help students to understand how they should interpret the measure prevalence or incidence and the metric in GBD Compare percent?
Percent is the trickiest measurement in GBD because we use percent as the percent of our total estimation. So I think like the easiest way to interpret percent with GBD is thinking about deaths. 20% of deaths are due to this cause. When we're looking at prevalence, most people think of prevalence in percent as percent of population that has prevalent with this disease. We have that measure in GBD. It's not what percent is showing us. It is instead what rates are. Because if you have, 200, let's just do 20,000 Per 100,000 that are prevalent with diabetes in a location, that's 20%. So we can take out percent from the estimates that we're showing, even though percent is often used a different way when we're talking about prevalence. When we're talking about percent with prevalence as it relates to GBD, what we're talking about is the total number of cases of all diseases. What percent are these diseases? I'm actually going to go back and share my screen. Let me get it out of Japanese for a second before I share. I think that a really effective tool to show how prevalence percent, or when we're using the metric percent when looking at prevalence in GBD, is not the way we normally think about percent and prevalence, is to look at this tree map with prevalence. So when we look at prevalence as a tree map, we see what we're looking at is like 50% oral diseases, oral cavities. We see that what we have here is a huge prevalence of a huge proportion that is due to oral disorders, but that's not really the percent here. So we can instead look at this map view. We can look at prevalence. We can look at oral disorders. And look at the different rates and translate that to percent. So Brazil, 52,000 per 100,000, 52%. Nigeria, 31,000 per 100,000, 31%, has some sort of oral disorder. Hope that does somewhat of a good job of explaining that.
Thanks, Scott. And I think we do have a number of additional technical questions, but I'm not sure, Carol, how we're doing on time. So maybe we can take note of these and follow up.
Allie, we're fine, actually. Why don't we take the next 10 or 15 while people are really engaged with the questions so that we can answer them live? I think that's really helpful.
Perfect. Well, Scott, we have a question from Amar asking, do we control for risk factors as well as filter for confounders?
Yes. Yes. I mean, so there's a little bit of like two separate parts of this question. When we think about risk factors, we also think about that in the first step of the modeling process, or maybe not really risk factors, but different measurements and tools and data that we can use to help us understand health. These are, things that are like positive risk factors, like prevalence of mosquito net use. So we control for those things when we're modeling. The confounder part of study, that is something that more usually comes out in the meta-analysis that we do to establish relative risk. So when we're establishing our burden of proof, what we call our measuring the relationship between exposure on population and health outcomes, we look into those different confounders to establish that. But another, part of, why these risk factors are incredibly complicated is that they do have those interactions with one another, which is another confounder that needs to be accounted for. So long answer to yes, But yeah, there's a number of different things in there, and that's why our appendices for these papers are like 1,000 pages long.
Definitely. Thanks, Scott. Two more questions. Could you describe what the cutoff for a disease is to be labeled as a neglected tropical disease? Is it as listed in the WHO TDR? And how do you calculate the age weight?
So I'm not an expert on neglected tropical disease list. What's nice though is if we go to GBD Compare, if you go to the GBD results tool and just go to the neglected tropical disease, because that hierarchical list, you'll see underneath NTD, first tab, I think malaria is now categorized with it alongside that. But it will show all of the NTDs that we have with our neglected tropical diseases. Neglected tropical disease and malaria. So leishmaniasis, Chagas, schistosomiasis. You'll see the list of the ones that we include. We do have other neglected tropical diseases, and that's something again that you may have to look into the appendix to find out what is included in there. In the age weight, I think that is in reference to age standardization, maybe. So the age weight is taking, let's see. Yeah. So the age weight is taking the yeah. Sorry, malaria is not neglected. We just categorize it in the neglected tropical disease categorization. It's NTDs and malaria because it follows similar patterns of environmental impacts, being near different water sources, different ways to cover it, and also different or similar, researchers looking into those things. The age weights, if we're talking about age standardization, we look at what the shape of the population is. So globally, so, population, looking at a pyramid, population pyramid can look, very pyramid-y when a population is growing and younger, and then there's rectangularization when a population is older, aging, what have you. The global population looks, a little bit similar in between that. We take the rectangular population of the older aging populations and the pyramid population of the growing young, rapidly growing populations, and we make them all conform to the same shape. So we weight each of the rates in each age group to fit the same shape of the global population. So by doing that, by applying those age weights, we can then compare that aging population to that young population. Because a really young population may have, really high rates of, neoplasms, of cancers. But because there aren't as many older individuals in those populations, they won't show up if we're just looking at all ages. But if the rates are that much higher in that older population, then we, as researchers, do want to be able to see that. We do want it to show up when we're making these comparisons, because that is, a point of concern, a point of interest, a point of health population inquiry that we need to get to.
Thanks, Scott. A few more questions for you. We're really jumping around here, so keeping you on your toes. Can you maybe speak a bit about how a single cause of death, or how is a single cause of death assigned when there are multiple coexisting causes?
Yeah. So we do always have to establish a cause of death, and this is, what, the ICD codes show us, and there are some things that we do model in like our intermediate modeling, which are called underlying causes of deaths, and these are things like sepsis, right? Sepsis we're including in the model because that is something that will contribute to an organ failure, but the organ failure, is the cause of death. Arguments about what a cause of death, which is the cause of death, are long and storied in IHME history, in burden study history. But there is a kind of philosophy here that we need to establish what people are dying from. And so these deaths need to be categorically exclusive from one another, so we don't double count one another. We are modeling more of those underlying causes of death and publishing more of those things. So things like additional things that we can explore on GBD Compare, like ideology, are things that are modeled but that aren't really included in the framework of GBD. But it does come down to that philosophical underpinning of we need to establish what is the one thing that is causing death. So that is hard. There's also another thing, which if I was to go into the methods, I would go deeper into that. We do a process in our causes of death modeling called garbage code redistribution, because there's a number of things that are checked down on the ICD code that we don't think actually kills you. One of them is heart failure. Our heart failure is, something that happens, but it's not your cause of death. It was this ischemic heart disease that killed you. So we take the different things like heart failure and we redistribute them onto the actual causes of death. That is just another way that we're, establishing that, harmonizing these data so they're really directly comparable.
Scott, that was great. There are more questions that are still present. I know that. And then we're going to switch gears just a little bit and open up breakout rooms for folks who want to continue talking to Scott and asking further questions that are about sort of the GBD methodology. So Scott is still going to be able to answer further detailed questions that you might have. And we're going to open up, however, other breakout rooms as well. I'm going to share my screen to list the showcase of what those might look like if you're interested. So if you want to talk about how you might integrate this into your program or into your courses, that's an opportunity to do that. And folks who would like to talk about other things, we're welcome to offer that as well. So we're excited to have you jump in. If you are interested to one of these other areas, if you are interested in continuing the conversation with Scott, go to breakout room 1. And they're open now. And I'd like to, while we're here, as a full group, we'll join again at the end. I know some people have been jumping off. I want to thank Scott and the GBD team that's here from the Institute of Health Metrics and Evaluation for a phenomenal presentation. Really just amazing. This is off the chart impressive to be able to learn more about the incredible power of this tool.
Well, thank you all for being here today. It's always an absolute pleasure to share this work. So do I join? So do I join
Yes,
breakout room
Scott,
one?
if you would be willing to go into GBD methods, that's breakout room number 1. And anyone who is looking to continue this conversation, that would be the place to go. Beyond that, we are trying to find a sense of community within our participants today. So we've got some different affinity groups, and we're hoping that they will populate with, say, 5 to 8 people. If you find yourself in a room of 1 or 2, we'd invite you to move to another room. If your room is more than 10 people and everyone doesn't get a chance to chat, perhaps look and see if there are other rooms where you might find people who would be able to talk about, in particular contexts, how GBD Compare and the other GBD tools are being used. So we'll go ahead and do that now. We'll come back into the main room for just a brief period at the end of our workshop. And again, thanks to everybody for dialing in. Thank you, Scott, for your presentation and for answering all of these questions here at the end, and the ones that you'll be answering in GBD methods, our breakout room number 1.
Thank you all.